Welcome back to the American College of Surgeons Bulletin Brief from the front line, Surgeons' Voices. With me today is Dr. Timothy W. Bax. Dr. Bax is from the Columbia Surgical Specialists in Spokane, Washington. Welcome, Dr. Bax.
Hi, thanks so much for having me.
Yeah, delighted you could be here today. Our mutual friend Tyler Hughes has suggested that you might be able to give us some insights into a very important and certainly decreasing in denominator segment of our fellows, and specifically people who are in private practice and not in an employment model, working full-time at a university clinic or hospital in some capacity. And you're definitely representative of that model of medicine, and in fact in a pretty large market catchment area. So it's an interesting kind of a paradigm that we'd like to hear a little bit more about. Many of our fellows members are in private practice, I'm sure benefit from your wisdom. So perhaps you could just start out telling us a little bit about Spokane and then a little bit about your group in terms of size of the market and size and constituency of the group.
Sure. Spokane's a community on the east side of Washington. Most people know where Seattle is. We're on the east side, just a few miles from Idaho. Spokane has about 300,000 people inside the city. The medical community is actually very advanced in Spokane. We're, roughly 300 miles from Portland, Seattle, Salt Lake City, and maybe Mayo Clinic, which would be the other big medical communities around us. So there's 1.5 million people or so that get their advanced healthcare in Spokane. And so it's a pretty big catchment area, even though it's a relatively small community. Spokane is, of course, most famous for the Gonzaga University Bulldogs, who were ranked #1 in the nation not too long ago. Lost a few games, but still doing well. That's how people have heard about Spokane typically, is through Gonzaga. My group has sort of morphed over the years since I've been in town for about 20 years. I originally joined a private practice general surgery group of 5 surgeons. That's merged with other groups along the way. Currently, our group, Columbia Surgical Specialists, has 11 general surgeons, 5 colorectal surgeons. That group merged with a group of ear, nose, and throat doctors. So we have an ENT side of our practice that's about 13 doctors. And then we've also picked up a few other folks along the way. We have 3 gynecologic urologists, as well as 1 solely breast surgeon. So we have kind of a smattering of people within our group. Even within our group, we sort of fashion ourselves as a little bit of a university style practice. For example, within the ENT part of my group, we have a couple of people that do head and neck cancer. We have a few people that do mostly sinus. We have a few people that do mostly hearing. We have a pediatric fellowship trained person. And same is true on the general surgery side, where some people are interested in complex abdominal wall reconstruction. I do mostly foregut. And so we have kind of a smattering of subspecialty without limiting ourselves to just that subspecialty.
Great. And can you give us an idea of the sort of geographic scope that you cover, how many hospitals and what sort of a radius might be included?
There's 4 hospitals in Spokane proper, 2 smaller community hospitals and 2 a little bit bigger hospitals downtown. My group covers all of the general surgery and trauma at the largest hospital in town, Sacred Heart Medical Center, which is a level 2 trauma hospital and the second busiest trauma hospital in the state. And then we also cover 1 of the other community hospitals. That's sort of what we do for local, responsibilities. But there are 35 hospitals in small towns outside of Spokane that refer to us. That you can get your hernia fixed in Colville, for example, a little town about an hour and a half away from here. But if you get in a car wreck, they're probably going to fly you to Spokane to get your complex stuff managed. So it's, like I said, 1.5 million people or so, catchment area scattered over, I don't know, we not uncommonly get people 150 miles away, sometimes 200 miles away.
The hospitals are all in the city areas. You're not going to rural hospitals per se.
Correct. Yeah. Well, we only practice in those down, it's kind of in the hospitals within our community, and then obviously get referrals from elsewhere, but we don't go to other hospitals. Correct.
Now, who helps you during the surgeries? Do you help each other? Do you have some kind of physician's assistants or surgeon's assistants? Are there residents or fellows?
There's no surgery residency in Spokane. There is a surgical residency at Madigan Army Medical Center in Tacoma, just south of Seattle, and we get a 4th year and a 5th year resident from there year round. So we do have some residents, but it's pretty limited. Most of the surgeries that we do with a surgical assistant that the hospital provides for us. It's just a second scrub tech essentially. We'll help each other rarely, actually, for complex stuff. But I actually really enjoy operating with my partners. We just don't tend to do it very much because we're all pretty busy. So mostly we have a second surge tech provided by the hospital, or sometimes medical students as well.
We've all heard about a national shortage in personnel in hospitals and in particular in operating rooms. Has that affected your group at all in terms of providing that assistance or the ability to get your cases done?
Yes, to some degree. Most of us are comfortable doing especially straightforward things with just one tech. So groin hernias, lap choles, I'll do Nissens with one tech, for example. And so we've expanded our sort of one tech repertoire a little bit because of that staffing shortage. We have our own surgery center for small outpatient stuff, and we've had a lot of trouble getting staff, just like the hospital has. So it's definitely been an issue. The hospitals, the main hospital I work at, or the two main hospitals that I work at, have significantly contracted the number of operating rooms that they can staff, mostly because they sent a lot of those people out into the hospital to care for COVID patients. They're now starting to call those people back. And so they're opening up more rooms, but we're still not up to full capacity. Plus we have 3 months worth of backlog to kind of catch up on. So it's definitely a struggle.
Yeah, it seems to be a national struggle. I've yet to speak to anybody who hasn't been adversely impacted in terms of the ability to do cases because of lack of personnel and the entire work model shifting from full-time employment to traveling, things like that. But you touched upon the other subject that I was just going to pursue, and that is COVID. And as it sort of goes in waves around the globe and within our country, between our east and west borders, north and south borders, it affects different people at different times. So clearly you guys seem to be in a recovery phase, but yet other places are not so far from you actually are kind of ramping up in their loads. Have you seen an uptick, or are you still on the downslope?
We are on the downslope of Delta. We have not seen, that I'm aware of at least, we've not seen Omicron in Spokane. Sure, it's coming. Our peak tends to lag about a month to 2 months behind Seattle. And Seattle is now a little on the uptick, which makes me nervous that in another month we will be too, but at least so far we have not seen that. We are actually starting to do a little bit more elective surgery, whereas 2 months ago we were doing none.
None 2 months ago.
Oh, we went from Sacred Heart, like I said, the biggest hospital that I work at, Sacred Heart went from doing 90 to 100 cases a day to 6 cases a day. Only emergencies.
Well, that's why you've got your 3 or 4 months backlog in cases, I guess.
Yes.
Yeah, that's a tough one. So what happens with the patients who are referred into your area? Do you see them and then just tell them to hold, or do they end up going back from whence they came to get their surgery?
Yeah, we've got really good leadership actually in our surgical department at the hospitals in town, and our group has adopted some of those same strategies within our clinic and our surgery center, which is we tend to put people into 3 buckets. There's look, this guy's got colon cancer, can't really wait, and needs to be done within weeks. Colon cancer might not be the best example because we all know they could probably wait a month or 2, but people that need to be done, relatively soon, not emergent, but within weeks. So for us, that would be within 2 months. So it has to be done within 2 months, can be done between 2 and 6 months, or could wait essentially indefinitely beyond 6 months. So like I said, I do a lot of foregut. So obviously my esophagus cancer is a little rigid and fixed by the radiation, but my Nissen patients, most of them have had reflux for 10 years. So they could easily wait a year if that's what it takes. They're not happy about it, but it's not a detriment to their health to have to wait. So we've been putting people in these various buckets. And then as some capacity opens up, we start calling them back based on what bucket they're in.
Sounds like a modification of the MENTS classification that we heard about from St. Louis University and University of Chicago last year. And it sounds like it's working. So the ACS certainly adopted and championed how to ramp down and how to ramp up for surgery. So I hope some of those different things have been helpful to your group. A question I want to ask you more generically about private practice. We have a lot of young surgeons who, I'm told, watch these recordings, and some of them are contemplating what type of career. So why should somebody go into private practice? What are the advantages of being in private practice instead of being employed by a group, a hospital or university or clinic?
But for me, it's about control. Basically, it's risk versus control. And COVID's a perfect example of this. When COVID happened in March, April of 2020, the risk is my group essentially closed. We laid off temporarily, fortunately, but we laid off 100 of our 140 employees, which was painful and miserable. And I was the president of the group at the time. We had meetings every week, sometimes twice a week, to try to sort some of this stuff out. And we all took a huge pay cut because of it. And our productivity went to near zero. But this was the advantage. We decided, boy, this telehealth thing looks like it might work. So we went to our front office scheduling folks and to our medical assistants and to our IT people, and we said, hey, we'd like to do telehealth. We want to do telehealth visits. We told them that on Monday. On Tuesday, we did 100 telehealth visits as a group. And on Wednesday, we did 400 telehealth visits as a group. I mean, there's just no way at a big institution that kind of rapidity can happen and you can get stuff up and running so quickly. We do work with the hospitals in town. We have contracts to cover trauma and acute care surgery with the hospitals in town. And so I'm familiar with dealing with the hospitals. And man, anytime any change needs to happen, it takes months and multiple layers of bureaucracy for that to happen. We have 30 docs in our group, but we can sit down as a group and say, this is what we want to do and make it happen tomorrow. So we have a lot of control. If I want to take 3 months and go to Africa to teach surgery, which I was interested in doing, I just need to convince my partners to give me a 3-month sabbatical. I don't have to go to some big institution that has 600 doctors and try to convince them or work out some system which they don't have already in place. So the downside is there's risk. All those employed physicians that work over at the hospital, they did not take a giant pay cut. The hospital, of course, lost their shirt, but the doctors didn't. Whereas we all took an income hit. But the big advantage is we have control over how we want to run our practice, what kind of patients we want to see, what sort of insurance patient, insured or uninsured patients we want to see, how much charity we want to do. We sit down and decide all those things collectively as a group. So for me, that's the big advantage. I like to have that control. Some people are like, I don't have to think about that or make any of those decisions. Well, then go get employed. Then you don't have to think about any of it. But you're going to be told, sort of to some degree at least, told what to do and how to do it. And I like the independence.
Great. 2 other questions. One comes to mind about the telehealth. Was it easy or hard to get remunerated for telehealth services?
The good news is the federal government passed a rule that said telehealth can be treated as same as in-office visits. And so, to tell you the truth, I don't know that we didn't have some trouble, but I think we were pretty successful at getting reimbursed for those visits.
And then the other question is, so you've got this group, 14, 16 people doing similar things, general surgery, colorectal surgery, others. And the only people who get exposed to your group are from Madigan, 4th and 5th year. So from where do you get recruits? You're in Eastern Washington. How do people seek you out? Do you use a recruiter? It's a word of mouth. People already work there. We all know big institutions kind of tend to hire people they've trained for the most part because there's already a pathway or people have rotated there. How does it work in private practice?
We do have medical student exposure from the University of Washington. They send students over to Eastern Washington. And we have now hired our very first surgeon, a pediatric ENT surgeon that did their general surgery rotation with us many years ago. After the first week, I spent the next 6 weeks or 5 weeks trying to convince her to become a general surgeon, and she sadly went into ENT. But we hired her, and she's now in Spokane, so I'm excited about that. But to be honest, that's the only one. We have tried recruiters and have been nearly universally unsuccessful with recruiters. What we find is people call us. All of us trained at various residency programs, and so the places that we have trained know about us and know about our group. Actually, you mentioned Tyler at the beginning, and Tyler recommended us to a resident, and we unfortunately don't have any room currently, but people tend to call us. We have found that recruiting someone and trying to get them to come to Eastern Washington doesn't work very well. You got to find people who are interested in living in Eastern Washington. It's a great place to live. There are 5 ski resorts within 50 miles of my house. There's 200 lakes within 50 miles of my house, but the reimbursement's a little less and it's a smaller community. And so you got to sort of find people that are interested in living in a place like this. So we have found people tend to come to us. We don't have to do a whole lot of recruiting, which has been great.
Well, that's wonderful. Certainly been a pleasure speaking with you and very enlightening about some of the facets of private practice as well as the geography of Eastern Washington, all of the lakes and ski resorts. So I'm
it's a nice place to come.
Yeah, I'm getting a bit of an education. I'm one of those people who's been to the west coast of Washington. But thanks so much for your time. And I wish you and your group continued success. And hopefully we'll see each other in person at an ACS meeting somewhere.
That sounds great. Thanks for the invitation, and I'm happy to chat.